Practice.
Okay, this is my midterm checkoff for Nurse 333. My teacher is Jeffrey Rowe. I'm going to go ahead and lay the camera down and I'm going to start. That looks about right. Okay. Alright, so first when we meet a patient we want to, check their level of consciousness. I'm going to ask her a couple of questions just to verify that she can answer readily and answer them correctly. What is today?
October 24th, 2013.
Who's the president?
Obama.
Okay, and what's your name?
Cassie Collins.
And your date of birth?
5/17/91.
And where do you live?
Rush, Kentucky.
Okay. From those questions, just from a similar breakdown, we can tell that she's alert and oriented times 3. We do sometimes, though, have abnormalities. We have people that are lethargic. They seem to be a little fatigued. They may answer your questions slowly, a little slurred. Sometimes with alcoholics or drug abusers, we get the most lethargic. We also have what's attuned, where they maybe can hear what you're saying, but they can't quite fully understand it, or they can't explain what they want to say is right. They're unable to communicate. We also have what's called a stupor, where they're almost basically unconscious, except they're alert. They're alert, but they can't answer any questions. They don't act like anything around them arouses them. They're basically just awake, but in a certain state of kind of a coma. And that leads me to the next one, which is a coma. A coma is where most of them don't even react to any kind of stimuli. Some react to pain, some react to certain sticks and checks, but some of them don't. Depending on how bad the coma is, or how bad the injury was to be in the coma, or the disease process, it could possibly further be worse. I went ahead and checked my wife's skin prior to this video. She didn't feel comfortable undressing on the camera, which I understand, but I done looked her over. As you can tell, she's warm pink, not moist, it's dry. I don't feel a temperature. I'm going to check her temperature here in just a moment. I looked over her. She has no weird lesions. She has no bruises. She has no markings that would make me be of concern. She does have 2 scars located here and in the belly button for an endometriosis surgery that was performed about 4 years ago. I want to go ahead and talk about a couple of the skin conditions that you can have. Psoriasis is one of them. It's one of our more prudent ones in this area. It's described as a papule up to 3 centimeters. It's not filled with anything. Nothing comes out. We also have acne, which is a normal characteristic in people going through puberty. It's a pus-filled part of the skin. It's normal. We can have what's called a keloid, whereas there's trauma to the ear, and then we have growths all the way around the ear. You see those a lot. Scabies, another skin condition where there's tunneling from a mite of some sort. It's usually found on the hands, on the webs and fingers of the toes and feet, and it itches at nighttime preferably. We usually give them some permethrin or some spray and we can get rid of it. I want to go ahead and ask her a couple more questions though. Do you have any pain today on a scale of 1 to 10?
No.
No. When do you have pain?
Sometimes when I eat.
When you eat. She has stomach pain. That's what I'm doing my H&P on. She's on Prilosec Q-Day. It kind of hurts her. We usually use a heating pad or something. It usually helps out, and during the period as well she uses the heating pad. That's how we can rate pain in an adult. We use this 1 to 10 scale, but we also have another scale for children. It's 1 to 5, where it's a face that's smiling and then a face that's frowning, crying, and we tell them to point to where they feel. We also can see if anybody's in pain by checking to see if they grimace at their face. We watch their cues. We look and see if they're in distress, see if they can handle anything like that. I'm going to go ahead and check your temperature now as we're talking about the skin and moving on. I'm going to check it through the tympanic. Alright, 98.9. A little bit of a temperature. We like to see around 98 to 99, 98.6 preferably. But she doesn't have what we consider a low-grade temperature, where that's usually around 100, and then if it gets above that, we think that they need to go see somebody and get something done very quickly. I want to go ahead and start with the eyes now. I want to go ahead and talk about a couple of the things that can be wrong with the eye first, though, before I do the examination. We can have what's called nearsightedness, where they can see up close better than they can see far away. farsightedness, where they can see far away better than they can read up close. Usually glasses can correct this, or at least help out during to what activity they're doing. We also have what's called an astigmatism, where there's a blurred vision effect. It kind of distorts the vision and makes people sometimes have a hard time to deal with it. We can also have what's called a lazy eye, where the eye doesn't correctly move or look at a certain way. Some people can see out of them and others cannot. We can also have what's called conjunctivitis, which is an infection of the eye. We usually give them antibiotic eye drops. It can be caused by any kind of infection where we touch our face and our hands and we touch our eyes. Chlamydial infection as well. That usually comes in newborns though when they're born. That's why every baby gets the antibiotic drops as soon as they're born now, because chlamydia, a lot of people have it apparently, and they just better off be safe than sorry. I'm going to go ahead and check her eyes now for reflexes. Once I move the eye should constrict briskly, and then as I look at the other eye for the consensual reflex, it should also briskly constrict as well. So I'm going to go ahead and check the left eye. Okay. Okay, both of them reacted on the left and right eye. So now I'm going to check this eye. Okay, consensual and direct both react. Her pupils constricted to about 2 millimeters. They were about 3.5, 4 as I was checking them. The other one's only briskly, but from that I would think that her eyes are perla and that there's no further problems. Do you ever have any problems with blurred vision, pain?
No.
Ever headaches or anything? Have eye pain?
No.
Okay. Alright, so as we talk about the eyes now, I think that we've pretty much discussed that and done pretty good. I want to go ahead and check one more thing though. I want you to follow my finger. We're checking for what's called accommodation now. Okay, her eyes crossed, which also shows me that accommodation's working. Tells me that all the nerves are intact and that there's no problems as of right now further on. Okay, I want to go ahead and further on down. This is where I check. I didn't check the skin at first for this, but we check skin turgor. Responds readily, so we wouldn't think she's dehydrated or anything like that. I want to go ahead and take a listen to her lungs. I want to talk about the lungs for a moment though, before I do my assessment. I want to talk about where the sounds are best heard. On the anterior chest, we can hear the top lobes. The left lobe is also heard on the posterior chest because it only has 2 lobes. The right lung has 3 lobes. We listen anterior at the top, anterior in the middle, and then posterior for both the left and right, because as the chest expands we can hear a lot better down in the lower lobes. There's a couple sounds you can hear listening on a lung examination. We have what's called crackles. It kind of sounds like a wet, bubbly feeling inside the lungs when somebody's breathing in and out. It usually is an indicator of pneumonia or the beginnings of heart failure. The second sound we can have is what we call wheezes. That usually is a constricting. They're best heard on inspiration because they can't get the air in, not necessarily get the air out. That happens with our asthma patients, our COPD patients. We have what's called rhonchi. It kind of sounds like there's just something blocking the airway, like a mucus plug or something like that. It's best heard on expiration because the pressure pushing it out, you can hear it kind of try to open it up or push it. So I'm going to go ahead and listen to her lung sounds, listen for clarity in all the lobes, and I'm going to ask her a couple questions that have to do with lung health. Deep breath. Alright, left upper lobe's clear. Okay, right upper and right middle lower clear. Left lower is clear. Right lower is clear. All her lung sounds are clear. I don't hear any kind of wheezes, crackle, or rhonchi. I want to talk about the 3 places though that you can hear the 3 different type of lung sounds. We had the bronchovesicular, which is more on the borders of the sternum, around the 2nd, 3rd intercostal spaces. That is our about medium airways. It comes from the bronchi, which is best heard over the sternum. They're only heard over the sternum, the bronchi, and then the bronchovesicular heard on the sternal borders. And then we have what's called the vesicular sounds, which is the soft lung sound we hear all over the lung. It can be heard all through the lung, not just, the certain spots like the sternum and the sternal borders. It can be heard all throughout. It's a soft sound. We can hear it moving. It shouldn't have any kind of crackles, wheezes, or rhonchi. Hold on. Now, after we assess the examination, I want to ask her a couple questions. Do you smoke cigarettes?
No.
Okay, so from that learning question, we don't have to worry about cigarettes or any kind of cancers or increased at risks. Have you ever had a flu shot this year yet?
No.
No, we need to ask her about her flu shots if she wants to be interested in those. And she doesn't need a pneumococcal shot because she's not old enough to receive one yet. Alright, so now I'm going to examine the heart. I'm going to check her radial pulse with a pulse oximeter and also get her oxygen percentage. One of the first things before we even assess the heart, we kind of look at the body. We look around at the face, the fingers, the toes. We look and make sure that everything's warm and pink, just like with the skin. That shows us that there's good oxygenation in the blood. She does have no cyanosis anywhere. There's no blue markings, nothing to make me think that something's inadequate. Her radial pulse, as of right now, is 66. Oh, wait, I'm sorry. It is 80 right on the dot, and her pulse ox is 99. So that shows us that she's being oxygenated. So now what I'm going to do is I'm going to count her apical pulse and make sure that it is almost the same as her radial. Maybe off by 1 or 2 sometimes for human error, but it should be about the same. So we're looking for 80. I'm going to set my clock back here. Okay, I got 39, maybe 40. So as from that, from 30 seconds times 2, that's about 78 to 80. So that's about the same pulse. There should be no big difference in those, or it says that there may be a problem. We may look for different things. I want to go ahead and talk about the things we may be looking for if we see things like that, and I want to talk about the areas of the heart that we will assess. There is 4 main areas of the heart. We have the right atrium, the right ventricle, left atrium, and left ventricle. We can hear a lot of these sounds. We hear your classic S1, which is the it's the mitral valve and the tricuspid valve closing, and the S2 valve, which is the aortic and pulmonic closing. Those should be in synchrony. They should be closing at the same time, and you can hear with the bell of your stethoscope. They should be closing at the same exact time, and you should hear no differences in them. If you do, that's what we call a splitting S1 or splitting S2. That's not normal. They should probably seek further. I want to go ahead and talk about some of the different things we listen for. Murmurs. We have one of the big ones that I've noticed is the patent arterius ductus. That's like a machine-like continuous murmur. That's dangerous. They need to get that fixed as soon as possible. It happens in newborns a lot. We also have the systolic murmur. One of the systolic murmurs are heard under the left scapula here. That can be indicative of aortication of the aorta. That's not a good problem to have because that means adequate blood flow is probably not getting to where it needs to be. We also feel on the heart, you can feel different kind of beats, and if it's not syncing up, that'll give you some indication. I want to talk about where we want to listen. If you want to listen to the pulmonic valve, you want to listen at the second sternal border, second to third intercostal sternal border on the left. That's what they call Erb's point. That's where you can hear S2 the loudest. That's where you can hear it the best. You can hear the synchrony. Shouldn't be any problem. To the right of the sternum is the aortic valve. We listen to that over here in this area on the second, third, right sternal border. The mitral valve down here is best heard on the aorta. The mitral valve is best heard on the apex of the heart. It's down probably the 4th or 5th intercostal space. That is your loudest beat. That's where you hear your S1 the best. That's where I hear it the best, is in the apex of the heart. We also have the tricuspid valve right here on the 4th to 5th right intercostal sternal here, underneath the rib. That lets you be able to hear the S1 as well, but like I said, I hear it better at the apex. Her pulses are all the same. A couple different things that you can have. You can have different kind of rhythms. Some people have bradycardia, tachycardia. Bradycardia is less than 60. Tachycardia is considered above 100. Hers is right at 80, so she doesn't have any bradycardia or tachycardia. We can feel in the pulse. I would need an EKG to further clarify, but we feel in the pulse whether it's a good solid pulse blushing through. We don't want to feel weakness, tingling, any kind of whittling or any kind of weakness. She's got a good strong pulse. It's not bounding though, so there's no problems there. So I would think that she's in sinus rhythm from that. She would probably almost have to be unless she was hooked up to an EKG and monitored to see if there was any kind of problems like that. She doesn't have any irregularities that I hear of. I'm going to go ahead and listen around. I'm going to go ahead and explain some of the points. We're listening to the mitral valve right now. Good strong beat. Listening to the pulmonic now. And I hear S2, aortic. And then the tricuspid. Okay. That is the areas of the heart, and like I said, this is Erb's point. That's where you best hear S2. I'm going to go further on down now, and I'm going to start checking the valve. I'm going to assess for a couple things that have to do with the heart, though. I'm going to go ahead and raise our shirt up for this just so we can see it. Just from the seeing, we see that it's flat. We don't see any kind of abnormalities. There's no differences. They're both about the same. I noticed 2 scars where she had some endometriosis surgeries, like I said prior to the video. One of the first things I want to check for on the abdomen is I want to push around below the diaphragm and try to feel for pulsations of the aorta. She's not a prime candidate for this, but you know, these aortas can bust and have dire effects on a patient. I'm palpating and I don't feel any kind of pulsations. I'm going to go ahead and feel around. Abdomen's soft. There's no palpable masses. Everything's good and squishy, just like it should be in there. Once we look at this, we ask some questions. Sometimes I've already asked her. She experiences diarrhea. That's a side effect of the Prilosec, though. But she has to take it every day, or else the stomach pain won't let her to eat or drink or anything like that. As you look at the bowel, you also want to just make sure that there's no pain. She didn't flinch or anything. They may not tell you. I want to go ahead and take some listens to her bowel sounds. I'm going to make sure that everything's present in all 4 quadrants. We have the right lower quadrant is probably the best place to hear. I'm here clicking and gurgling within the first 5 seconds, so that's normal. Gurgling in the left lower. Gurgling in the left upper. And gurgling in the right upper. I'll put it down here. She has all 4 bowel sounds present. Usually within 5 to 10 seconds she'll hear clicks and gurgles. It should be a continuous, not fast-paced or slow. If they are slow, that's usually indicative of constipation. Sometimes with the effects of opioids and painkiller medicines, that can happen. Diarrhea, hers are sometimes hyperactive. I have listened at points where she's been sick, and I have seen how quick they can get, so now I know what to listen for. One of the indications when you listen to bowel sounds is that if you hear an abnormally high-pitched sound, that's usually indicative of a blockage somewhere. That's one of the early signs that it's trying to push it through and it just won't move through. I want to go ahead and look for abdominal signs of bleeding too. She has no Cullen's or Grace-Turner sign. Lean forward. She doesn't have any bruising or pooling of blood in the back or the front. It's good and warm. It's pink. It reacts quickly. It's not dry. I haven't noticed any dry skin. I did check her feet as well, since we're talking about dry skin. Fissures can happen with athlete's foot. You look between the toes. It's dry skin and it causes cracks, and that's why they call it fissures. Her abdomen is soft, like I said, no pain. I want to go ahead and, sorry baby, I have to test for ascites. One of the ways to test for ascites, I don't have an assistant, but I want to go ahead and explain the best way, because they say it diagnoses with a 3 to 6 ratio. So, you know, this is a 50%. This is one of our best tests. It's what we look for as a pulse wave. We look for a fluid wave to go over the stomach. She's not swollen by looking at her, but if we were going to test somebody for ascites, which is usually indicative of cirrhosis or a inferior vena cava problem, we want to have our hands like this, have our assistant hold their hands like this, and as we move the stomach up and down, we push. And if a fluid wave arises, that's usually about 50% chance indicative of ascites, but it's already present. But that's the best test to rely on. The best test as well for ascites is just to generally look at them. You can tell if somebody's swollen. Their contour of their shape, it'll be pooched out, it'll look tight. The skin won't look good and healthy like this. You know, it won't be flat. It may have certain areas that are bigger than others because of the different kind of leakages they can have. I want to go ahead and talk about some different kind of wounds that we can have. The one I've experienced most is in my nursing home is that pressure ulcers. We stage those stages 1 through 4. 1 being, you know, just the top skin of the layer is excoriated, maybe has come down to the second layer of skin, and then on down to stage 4 where it's deep tissue and deep tendon muscle being damaged. We also can describe those as partial thickness and full thickness depending on how deep and how the skin looks around it. We have different sort of things that I've seen. I've seen puncture wounds by accident. As long as you can stop those from bleeding, you're pretty much okay. I've seen hematomas, ecchymosis. I've seen different things. We look for bruising. There's none of that present on her. She doesn't have any swelling at the feet noted neither. As I keep on moving down, it's none noted. No pitting edema at all. So I really don't think she has any health problems at all just from this. I mean, I know that she has the stomach problems, but after this assessment, I think that she's pretty well aware of everything in her body, and she keeps up good with it. She doesn't have any IV sites or anything like that. She doesn't have to receive any medications, no shots, no pills, except the Prilosec. I want to go ahead and talk a little more about some wounds that can develop. They're not technically wounds, but it's skin conditions along that line. I just want to hit on that some more because I don't feel I touched on that as good. We have a couple different kind of skin conditions. I want to go ahead and touch on 2 different types of cancer, 2 totally different kinds of cancer. We have what's basal cell carcinoma. It's a skin cancer. It does metastasize, but it takes a very long time to grow, and it usually does not happen. Usually happens in older adults. It can happen in any age group, though, as cancers we have seen here lately. But as you watch the cancer, it doesn't grow quickly, and it can be contained. But on the other hand, we have a melanoma. I've looked all over her body because she has some suspicious nevy, but after further examination, we took her to the doctor. I don't think that there's any kind of certain like that. It's just a mole, just a regular nevy. As I look for melanoma, I look for a irregular shaped mole, maybe blackness in color, dark brown, irregular borders. It's not symmetrical at all. It could be different shapes, could be different ways. And we look for that, and we need to get a skin biopsy as soon as that because that's one of the dangerous cancers. It's very quick, it can damage, and it can end somebody's life prematurely when it shouldn't be ended. We can have certain excoriations. We can have dry skin. That's usually our first excoriation. Bruising, we can see bruising underneath the skin. We can have blood blisters. Those are usually blood-filled blisters that pop up. Kind of like an insect bite, but an insect bite is filled with serous fluid. The same as with herpes zoster. It's filled with a serous fluid usually found around the mouth. Herpes zoster is chicken pox. It comes around the back, and then it can turn into shingles, which is actually the herpes zoster. I think that that's pretty much all of it that I can think of right now. I think I've assessed her pretty good from head to toe. I think I hit on all the key points on the checkoff list. And if there's any question, Jeff, just send me an email or call me. Thank you.